Good day everyone. Welcome to Management of Convulsive Disorder lecture. Seizure, fits, and convulsions are terms used interchangeably. Epilepsy, on the other hand, is slightly different. Seizure is defined as a transient occurrence of signs or symptoms due to abnormal excessive or synchronous neuronal activity in the brain. While epilepsy is a disease of the brain, defined by at least 2 unprovoked seizures occurring more than 24 hours apart, or diagnosis of an epilepsy syndrome. When a patient is admitted with first episode of unprovoked seizure, the first question we need to ask ourselves is, was it a seizure? There are a lot of abnormal movements mistaken as seizures. This include tics, dystonia as well as sleep myoclonus, to name a few. If you are sure this is a seizure, the next thing to do is to classify them. There are many classifications which has been revised and updated by International League of Epilepsy, ILAE. The latest classification has been published in 2017. This framework shows that there are 3 levels involved. Level 1 is classification of seizure types based on the seizure onset. The seizure onset can be categorized into 3. It is either focal onset, generalized onset, or unknown onset. For focal onset, the patient could be aware during the seizure episode, or having impaired awareness. Motor onset is when the sign can be seen by the observer, while non-motor onset is symptom experienced by the person. Focal onset seizure can then progress to bilateral tonic-clonic, previously termed as secondary generalization. For generalized onset, there is impaired awareness in general. It is also categorized into 2, motor and non-motor.
Good timing.
Most of the time, seizure is only noticed by others midway, thus the category unknown applies. Now that we have established the seizure type, we need to find out the cause. Referring back to the framework, the etiology can be divided into 6 categories. The categories are structural, genetic, infectious, metabolic, immune as well as unknown. In each categories, further examples can be found. For example, patients with Dravet syndrome is categorized under genetic due to the SCN1A mutation. Next, the key question is of course regarding how to manage a patient with seizure. History, physical examination, appropriate investigations will then lead to the optimal treatment. During history taking, it is important to determine seizure type, duration, time of occurrence, as well as possible precipitants. Symptoms of increased intracranial pressure need to be explored. Other components of history taking, especially developmental milestones, play a crucial role. In physical examination, we need to be able to identify Cushing's triad, which indicates increased intracranial pressure. Neurological examination in children less than 5 years old are often challenging, hence observation is the key in obtaining abnormal signs to achieve a diagnosis. In terms of investigation, it is important to rule out easily corrected cause of seizures first, such as hypoglycemia. EEG is usually not indicated during inpatient stay. All focal seizures will need a neuroimaging at some point. There are pros and cons between CT and MRI for neuroimaging in children. Even though MRI would be the gold standard, in case where space-occupying lesion such as intracranial bleed is suspected, easily obtained CT would be more of benefit. Patients with seizure can usually be discharged after being seizure-free for 24 hours. Parents need to be informed and taught about seizure precautions and first aid measures. General consensus is not to treat patients with anticonvulsants after a first unprovoked seizure. Parents also need to be informed about risk of seizure recurrence. There are several risk factors which could help us to predict patients with higher risk of seizure recurrence. For first episode of unprovoked seizure, there is 1/3 rate of recurrence, and risks increases with each subsequent episodes. Status epilepticus is defined as continuous seizure for 30 minutes or more, or recurrent episodes of seizure within 30 minutes with no regain of consciousness in between. This algorithm is taken from the latest Malaysian pediatric protocol. Febrile seizure is a topic that has been covered in Year 3. You are expected to know the difference between the two, in terms of duration, seizure type, frequency within 24 hours as well as residual deficit. Coming back to the framework by ILAE, Level 2 is epilepsy types. Classification of epilepsy type is important to determine our line of treatment. It can be categorized into 4, focal, generalized, combined generalized and focal as well as unknown. The key concept in pharmacological treatment for epilepsy is related to the voltage-gated ion channels situated in the neurons. Sodium valproate is the first-line treatment in generalized epilepsy, while carbamazepine is the first-line treatment in focal epilepsy. AED is always started at the lowest dose possible and titrated slowly. Different AED works at different channels. In choosing a second AED if required, we need to understand that it should not be working on the same site. Non-pharmacological treatment for epilepsy include ketogenic diet, epilepsy surgery, vagus nerve stimulation, and deep brain stimulation. However, DBS is still not available in Malaysia. Level 3 in the framework is the diagnosis of epilepsy syndrome. Epilepsy syndrome is defined as a cluster of features incorporating seizure types, EEG, and imaging features that tend to occur together. There are several epilepsy syndromes that you need to know. Childhood absence epilepsy has a pathognomonic EEG finding of 3 Hz generalized spike wave complexes. Usually mistaken as daydreaming, this type of epilepsy usually treated with sodium valproate. This epilepsy syndrome is previously known as benign Rolandic epilepsy. Associated with good prognosis, patients usually do not need to be on treatment with spontaneous resolution seen by adolescent period. Juvenile myoclonic epilepsy is commonly associated with photosensitivity, even though can be well controlled with sodium valproate. Usually patients need lifelong treatment due to high relapse rate. West syndrome is a triad of infantile spasm, hips arrhythmia and developmental delay. Associated with poor prognosis, urgent referral to pediatric neurology is often required to ensure prompt diagnosis and treatment. Even though uncomplicated epilepsy can be managed at general pediatrician level, there are certain circumstances in which referral to pediatric neurology is required, as listed in this slide. Epilepsy is a very vast topic. I hope this lecture helps to give you the basic understanding to initiate further reading in this subject. Thank you for listening.